This program is brought to you by Emory University.
We're doing something a little different for this morning's grand rounds. Before we get to our main presentation by Dr. Tanveer Rab, we're going to have two of our fellows give short presentations. First, we have Dr. Asaba Islam, who's one of our ECRI fellows, who's been working on some interesting findings related to social vulnerability and COVID. So she'll present her work on that. And then we will have Dr. Ahmed AlBadri, who's been a fellow in the CCU, present a case and his experience. Go ahead, Saba.
Hi, everyone. Good morning. Thank you for having us present our research work. I'm Saba. I'm one of the cardiology fellows, and I worked on this closely with Aditi and Anurag under the mentorship of Dr. Kayumi. We looked at the association between social vulnerability and race and ethnicity and COVID-19 incidence and outcomes in the United States. So there's been a lot of news reports on disparities during the COVID-19 pandemic. On the right-hand side, you can see some screenshots of news reports highlighting disparities within the Black community. There's been a few perspective articles too. Last week, the New England Journal published something on the coronavirus and the Navajo Nation. And a week and a half ago, JAMA published something on COVID-19 and African Americans. These were very thoughtful pieces, and I highly recommend reading them, but there hasn't been much empirical evidence that has showed these trends. So our goal was to study the association between county level social vulnerability index, which is a measure of social vulnerability to disasters and racial composition, with the incidence and case fatality rates of COVID-19 in the US. So I will go over the social vulnerability index very briefly. It's designed by the CDC. Again, it's a county census tract level measure of vulnerability to natural disasters, which includes pandemics. It's a percentile based system. So the higher the percentile that a county is in, the more vulnerable it is. It's a conglomerate of 4 different factors, including socioeconomic status, household composition and disability, minority status and language, and housing type and transportation. So so moving on to our methods, we used all publicly available data. We obtained incidence and case fatality data from US counties with at least 50 confirmed cases of COVID-19 as of April 14th, and that included 674 counties. We assessed county level associations of social vulnerability index and racial composition with COVID-19 incidence and case fatality rates using generalized linear mixed effects models, and we adjusted for county level age, comorbidities, and state level COVID-19 testing. Our results showed that higher social vulnerability index is associated with increased COVID-19 incidence and case fatality. So if you look at the first row, for every 10 percentile increase in a county's social vulnerability index, the incidence rate goes up by 5%, and similarly, the case fatality goes up by 5%. These associations are driven through socioeconomic status, minority status and language, and in terms of case fatality, also crowded living condition and poor transport accessibility. And these are all adjusted for age, comorbidities, and testing rate. Looking at the racial breakdown, so we see similar trends over here for Black and Hispanic race. So for every 10% increase in Black race in a county, the incidence is up by 22%, and the case fatality is up by 12%. Again, these numbers are adjusted for county level age, comorbidities, and state level testing rate. We know that the data is continuously evolving, so we created a dynamic map of social vulnerability index, race, and COVID-19 outcomes. I have a screenshot of our map over here, and you guys can check it out on the ECRI website. This is data from April 21st, and we have highlighted counties that have the highest vulnerability and also the highest case fatality. They're highlighted in red, and you can see there are 223 counties, and you can see the Navajo Nation is there, Detroit, Chicago, and going into, if you zoom in, I have highlighted Fulton County over here, so you can see the social vulnerability index, incidence, case fatality, the racial composition of the county, and you can see we are red in Fulton County. So to conclude, higher social vulnerability is associated with higher COVID-19 incidence and case fatality rates, independent of age, medical comorbidities, as well as testing rates. The associations are driven by lower socioeconomic status, poor housing conditions, and higher minority populations. And delving deeper into the minority population, we see that higher Black and Hispanic populations have worse outcomes. We have identified counties where the most vulnerable counties, which have both high SVI and worse outcomes, and we hope that public health interventions can be directed there. The preprint is available on this website if anyone wants to check it out. And I would like to thank everyone on the research team who've put in countless hours in this project. And these are our data sources, and as I mentioned, they're all publicly available. And here are the references, and thank you, and I'm happy to answer any questions.
Okay, great. Thank you, Saba. We're going to take all the questions and discussions at the end. So now let's have Dr. Ahmed AlBadri present his case and experience.
Morning, everyone. Thanks for having me. Thanks, Pooja. I have nothing to disclose. These are quotes, some quotes from fellows over the past month or so when we were talking and interacting with each other. And of course, it demonstrates the concern, the anxiety, the fear, physically, mentally, and also there's a lot of concern about the career-wise in the future. I'm one of those fellows who felt at a certain point lost, anxious, and afraid of not knowing what to expect next. I'm going to share with you one of the cases that I took care of last month in the CCU. And I learned a lot from this case, not necessarily clinically, but for sure, kind of ethically and somewhat, I was able to adjust and accept the reality of this pandemic. This is an 84-year-old male with significant confusion and shortness of breath. He was directly admitted to the CCU from an outside facility. He has a past medical history of diabetes, hypertension, coronary disease, end-stage renal disease, and has a surgical history of CABG. Patient was worked up for outpatient dialysis. However, the dialysis was not started yet. On physical exam, you can see he was sitting at 92% on a rebreather mask, very confused, fully responding to the surrounding. He has a JVD, very elevated, plus 2 pitting edema, and he was in moderate respiratory distress. So I was in the room with the nurse assessing the patient quickly after they rolled the patient into the room. And then, of course, we ordered an X-ray. So the X-ray tech came to get the images, and also some blood work that the phlebotomist came in also to the room. I was reviewing at the same time the outside record, and you can see there's a significant elevation of his creatinine from 5.5 to 18.2. The BUN was 86 to 210. He was acidotic. He was anemic, but at the baseline, pretty much. BNP was 943. This is his X-ray when the tech just took the picture. And you can see there's a vascular congestion, probably at the bases, and maybe there's some infiltrates that's suggestive of questionable pneumonia. At the same time, we get a call from Emory University Hospital that the patient's daughter is admitted to Emory University Hospital with COVID positive, and she lives alone with the patient, and she just wanted us to let us know. At that point, there was a mixed feelings of anxiety and panic, and I didn't really know how to react at that moment, as I felt really lost. And this was when we just started to learn about the coronavirus here at Emory, and when initially trainees were not allowed to interact with COVID-19 patients. At that point, I didn't know how really to kind of use PPE appropriately, except watching a few training videos. And on social medias, I saw the Chinese physicians that wearing 3 layers of protection, and I was interacting with a patient just right now without any protections. And at that time, the COVID test needed approval first, and it would usually takes about 2 to 3 days to come back. 5 minutes later, the nurse called me that the patient is in ventricular tachycardia. So I was going to the room and then have a lot of those thoughts of, should I go in? What should I do? And I felt a lot of stress at that point. Of course, it's a non-COVID unit, so the PPE were limited. We didn't have PPE at a certain point. And the nurse manager was able to get me the N95, a gown, and I went in to assess the patient. Patient initially was unresponsive. The nurse started to do a CPR. We put in the pads and we shocked the patient, and he regained ROSC and intubated at that point. So I start rounding after that on the other patients. The attending came in, we rounded on the patients, and we had a plan for every patient. Then 45 minutes later, I went to check in on the patient, and I was looking at through the window, and the nurse who was with me, she was still in that room taking care of the patient and making sure he's stable. And actually that moment truly changed the way I was thinking and made me overcome the anxiety and fear. I realized being a physician is a dangerous job, but I signed up for this, and I have to take care of I have to take the risk. The nurse made the patient her priority, regardless of the risk and his illness, and I realized I should do the same pretty much. Of course, 3 days later, the patient was tested positive at that time. I put in kind of like what I call like kind of the grief cycle that I think I went through in the era of the COVID-19. First, I was probably in denial, thinking that everything is going to be fine. Georgia's not going to get hit with the coronavirus. And then followed by the fear and anger once we started seeing these patients and how they do poorly. I think now I'm in the stage of acceptance of we have to deal with this, and hopefully recovery very soon. In summary, during this turbulent time, I think we as a doctor, we cannot run away. We have to deal with the facts. Therefore, please hear us, protect us, prepare us, support us, and care for us. As fellows, of course, we need to support each other. Thank you so much. I think I have to give a big shout out to the staff in all the units, especially the 11 and 41 ICU that I worked with. And of course, to Dr. Williams, who's been always a support to his fellows. Thank you so much.
Okay, great. Thanks so much, Ahmed, for that great perspective. Next, our speaker is our main speaker, Dr. Rab, who is a professor and interventional cardiologist here at Emory, who really needs no introduction. He's going to talk to us about COVID and cardiovascular system.
Good morning, everybody. Can you hear me, Pooja? Can
Yes.
you reach the screen?
Yes.
So my full disclosure, I'm no expert, but having a lot of free time, I've been trying to keep up with this literature on a daily basis. So this is sort of a summation of looking at all this stuff that's out there, particularly in relationship to COVID-19 and the cardiovascular system. So Bob went over this. I'm not going to go in more detail than we're close to 1 million people with over 55,000 deaths in the US and around 904 deaths in Georgia with approximately 22,000 cases. The total number in the world is close to 3 million now. So how does the virus work? As you know, this actually is a virus with a lot of little spikes on it. In the host cell, there's a transmembrane protease serine 2 molecule that activates these spikes in the COVID molecule, and then it attaches itself to the angiotensin converting enzyme on the host cell. And that's how it gains entry into the cell. And this is the way it uses host cell entry. It should be noted that there's increased concentrations of ACE2 pneumocytes, and the concentration is 50% higher in hypertensive men. And therefore, men with hypertension have higher incidence and complications from this disease. Once it enters the host cell, there's downregulation and decreased levels of ACE2. ACE2 is required also to convert angiotensin 2 to angiotensin 1. But because ACE2 is decreased, there are increased levels of angiotensin 2, which cause increased inflammation, vasoconstriction, and thrombosis. So this is how it lands in the alveoli. Basically, it causes virus-membrane interaction with virus replication, virus dissemination, followed by endothelial dysfunction, platelet activation, neutrophil platelet aggregate formation, neutrophil migration, fibrin thrombus formation, resulting in ARDS and also alveolar hemorrhage. And finally, when there's diffuse alveolar damage, there's more hemorrhage, platelet consumption, and DIC-like picture with coagulation factor depletion and diffuse alveolar hemorrhage. What does it do to the circulation? We've found out more recently that it really induces vasculitis with intense thrombus formation. Thrombus formation is coronary circulation due to intense acute inflammatory response, which can also, due to the stress that the body is undergoing, there could be other reasons to also cause plaque rupture and vulnerable plaques, and endothelial cell dysfunction, increasing procoagulant activity. Some reports say there's a acquired antiphospholipid antibody. All these factors exacerbated pre-existing cardiovascular disease. The effects can be predominantly thrombotic with the VT and DVT with embolism. Patients can sustain myocardial infarction. More recently from Mount Sinai, in New York, they've seen younger patients with strokes due to large vessel occlusion. And also, the renal arteries can be affected, causing acute kidney injury. Also, as part of major multi-system organ dysfunction, you can get acute kidney injury. And then there's also thrombosis of cannulae and dialysis catheter, as well as ECMO catheters. So how does it present? The population risk, generally male more than female, age greater than 60. Hypertension, 30% of cases. Diabetes in 8 to 19%. Cardiovascular disease as a 5 to 8%. Of COPD, small number, 3%. Majority of patients have mild symptoms. Symptoms include fever, dry cough, fatigue, chills, myalgias, and some cases diarrhea. However, dyspnea is present and along with productive cough in 20% of cases. Case fatality rate about 1.4%. The risk of death in hospitalized patients close to 20% or so. The worst outcomes is a cytokine storm, which is due to direct viral attack on T lymphocytes with hyperimmune response. It's associated with increase of all these factors, including IL-6, D-dimer, ferritin, and LDH levels. So the Chinese classified COVID-19 into 4 different types. The mild type, which clinical symptoms are mild and there was no signs of pneumonia on imaging. If in China, everybody got a CT scan when they came in, suspected COVID-19. We're not doing that in this country right now. A lot of people just get chest x-rays, and a few may get CT scans if ARDS and pneumonia is suspected. In the ordinary type, you can get fever and respiratory symptoms, radiological findings of pneumonia. In the severe type, there's respiratory distress with marked oxygen desaturation. And in the critical type, of course, they go into respiratory failure requiring mechanical ventilation, multi-system organ failure with shock. In Italy, and again in other countries, and also New York, majority of cases are men with a median age of 63, half had hypertension, and 99% needed respiratory support. Mortality was 26%. Italy was quite unprepared. There's an older population in the Lombardy region, and they've had a higher number of deaths than other countries. So overall mortality in China was initially reported 3.4%. They revised the numbers recently, and it's at 5.6%, very close to what we see in the United States right now, 5.6%. Italy had a higher mortality at 13%. They're totally unprepared. Mortality in Georgia has crept up from 3.4% to 3.9%. Again, as just alluded to, this disproportionately high affliction minorities, particularly African Americans, with overall 50% mortality rate. So the illness has a sort of a asymptomatic phase with viral shedding, and then symptoms onset generally occur in a week, and by days 10 to 14, ventilation may be required in some cases. And I'll come to this a little later. In many of these cases, you'll see a trend towards the rise of high sensitivity troponin, NT-proBNP, and the cytokines such as IL-6. By day 2021, some folks will recover, but if they don't, they have increased vasculitis, coagulopathy, increased risk of heart failure, and cytokine storm with multi-system organ failure. And the cytokine storm is really a dysfunctional immune response with profound lymphopenia and hematophagocytosis. And most patients, those who die, generally die within 20 days, 20 to 28. So this is a time course, as Zhao from China illustrated. The generally sepsis sets in around day 10, ARDS by day 12, acute kidney injury, acute cardiac injury by day 15. Multiple secondary infections occur a little later, and by day 20 or so, death occurs. And when these markers, particularly D-dimer, shows a rising trend. I'll show you the numbers later. Lymphocyte count actually decreases significantly. IL-6 goes up, serum ferritin goes up, high sensitivity troponins go up, and again, lactate dehydrogenase goes up. So those are the markers that one needs to keep an eye on. Majority of deaths are respiratory failure, but if we take myocardial damage and heart failure, the combination of the two results in the majority, at least 80% of the deaths that occur. And again, the markers are rising troponins, rising myoglobins, C-reactive protein, interleukin-6. So I've made a summary slide for laboratory markers for dysfunctional immune response and impending cytokine storm, and generally days 10 to 13, that this portends a progression to ICU care, mechanical ventilation, the critical course, and poor outcome. So what are the numbers to look at and see the trends on? Lymphocyte count less than 600, LDH greater than 550, IL-6 rising from 18 picograms to approximately 30. Troponins less than 4.4 were not felt to be a significant marker. They were felt to be like a type 2 MI, but again, the critical threshold of troponin rise around 26, CRP greater than 60, ferritin greater than 330 micrograms per mil, and NT-proBNP greater than 800. The rising trend of these numbers, these are the sort of threshold numbers I've looked in the literature to suggest impending poor outcome and ICU care and possibly progression to cytokine storm. So myocardial injury occurs in 1 in 5 patients, leading to ACS, heart failure, shock, cardiac arrest, and death, even without signs of respiratory failure. As you know, serious medical events can cause stress and damage to the heart with type 2 MI. Pneumonia and ARDS can cause widespread inflammation and vulnerable plaque rupture. 2 published Chinese studies suggested 19 to 20% myocardial injury rate with 1 in 5, with a 51% mortality rate in those who had myocardial injury. And troponin elevation is very high in critical patients, greater than 3 times the equivalent to normal. Again, the survival, those with cardiac injury, the survival was low versus those without cardiac injury. The time from both in time from symptom onset as well as time from admission. What level of troponin? So this was also looked at by our Chinese colleagues, and the threshold was around 26. Troponin greater than 26 in severe disease is a marker of poor outcomes. So what are the complications of patients with COVID-19 in the ICU? The main thing is, of course, ARDS, followed by arrhythmias, shock, acute cardiac injury, and AKI. Those are the biggies that these patients have as outcome, a poor outcome for those who go to the ICU. So how do you manage STEMI in patients with the COVID-19 pandemic? This was a joint statement that just came out on April 20th from ACC, SCAI, and American College of Emergency Physicians. So if you have ST7 elevation on the EKG and your COVID-19 positive probable and symptoms consistent with MI and ECG consistent with MI, consider a focused ultrasound to confirm wall motion abnormality. If that is concerning and there's a wall motion abnormality, this may be true STEMI. You go through primary PCR with full protective gear. Of course, some places have ultra-rapid COVID-19 testing, such as the Abbott point-of-care testing. Now, if you have any equivocal symptoms and atypical ECG, again, you should do echocardiogram to detect wall motion abnormality, do a ECG portable chest X-ray, and consider COVID-19 myocarditis. The ED and interventional cardiology teams make a joint decision regarding possibility of coronary CT angiogram or cardiac cath lab activation. If you have COVID-19 possible and symptoms consistent with MI and ECG consistent with MI, again, use protective gear and treat it like a STEMI. Now, this document really enforced the concept of the full PPE for these cases. The door to balloon time metrics, I think decision was made not to worry about that right now in this pandemic. Now, this is from Twitter. There are STEMI mimetics with normal coronaries, and this can occur with myocarditis, stress, cardiomyopathy. The important thing is hyperacute ST segment elevation due to which suggests acute injury. But again, in all of the EKG tracing, you'll see no reciprocal changes in the other leads. So STEMI activation in this country have declined with a 38% reduction in STEMI activations versus this parallels Spain, which had a 40% reduction. Italy had a higher reduction, close to 80% reduction in STEMI activations. And potential cause for decline include avoidance of exposure. Patients are not coming to the medical system or activating the 911 call. Sometimes there's misdiagnosis of STEMI, and a number of places prefer pharmacological reperfusion, such as thrombolytic therapy to protect medical staff from COVID infection. So the question being asked, where are these patients? Are they dying at home? We'll never know, because as you know, in New York State, those patients died at home. It was encouraged that 911 not be called to take the patient to the hospital or to come in to pronounce dead because the EMS service is so busy. So we will never have a registry to find out actually whether patients really had STEMI at home or died from cardiac causes. What about non-STEMI? This I like this algorithm from the Oshner Clinic. What they suggested was aggressive guideline-directed medical therapy, unless there was hemodynamic instability or electrical instability, with ongoing evidence of myocardial ischemia or a gray score greater than 140. And those, again, could go to the cath lab with PPE protection. Otherwise, aggressive guideline-directed medical therapy and discharge for later follow-up. What did the interventional cardiologists think in the poll that's conducted by the ACC for COVID-19 confirmed patients with STEMI? The majority of 43% preferred thrombolytic therapy to reduce exposure versus 33% who wanted primary PCI, and others were sort of in between or neutral. What about non-STEMI? The majority, 63%, favored medical therapy. I created this pyramid out of this Sky Shock pyramid and sort of suggested a ABCDE level of classification. So A means asymptomatic, COVID-19 naive or exposed. Again, primary PCI with PP precaution. If you have the borderline sick with COVID-19 positive who may require hospitalization, but they're responsive to antipyretics but bronchodilators, again with PP with N95 mask and goggles. If you're C or critical sick or intubated on a ventilator, again PP and N95 mask and goggles, full body protection, or PAPR, powered air purifying respirator. If you're deathly with marked hypoxemia despite ventilator and hemodynamically unstable, one could consider fibrinolytic therapy rather than primary PCI, as well as VV or VA ECMO for age less than 60. And if you're an extremis or E, unlikely to survive, reperfusion therapy was likely of no benefit. There's a greater than 70% mortality with fulminant myocarditis, which occurs in 7% of cases, but the use of ECMO has been less than 5% worldwide. And multiple factors such as ARDS, septic shock, multi-organ failure, and fulminant myocarditis are terminal events in these patients who do not survive. What is ECMO use? In North America, there have been 256 patients, and 88 have completed ECMO with a 38% discharge alive. In Europe, 97, 20% discharge alive. Asia Pacific had very low use, and discharge alive was a very low number. Majority of cases are VV ECMO. Emory experience has been 4 patients with 100% survival. There is some literature that suggests permissive hypoxemia for the younger person, where O2 stat of 88% is allowed, but the primary therapy is VV ECMO rather than intubation, thought being the patient could use, be better off trying to help expectorate his sputum from underlying pneumonia. But again, this is a very small number of cases published in another country where they had survival, about 4 patients where that approach was taken. What about the differential diagnosis of a condition as COVID-19 associated coagulopathy or CAC? So the differential diagnosis between PE, ACS, including STEMI, non-STEMI, and cytokine storm is shock. So troponin I is low in pulmonary embolism, low less than 4.4. ACS STEMI would be higher, greater than 26, and cytokine storm is markedly elevated. D dimers, again, are elevated greater than 1 microgram in PE, but low levels ACS, STEMI, non-STEMI, and markedly elevated greater than 3 micrograms in cytokine storm shock. What about focused handled ultrasound? Of course, in pulmonary embolism, we see RV enlargement strain. In ACS STEMI, non-STEMI, they will have focal region wall motion abnormality. And again, cytokine storm will have LV dilatation, global LV dysfunction. A D dimer greater than 3,000 nanogram or 3 micrograms per mil has a 4-fold increase in mortality. There's also a score from the Thrombosis Hematology Society where they do a plate count testing, a PT and INR, and a SOFA score, and score greater than 4 has a greater than 50% mortality. So what is the presentation of COVID-assisted coagulopathy, CAC? So of course, we look for DVT and PE for patients in bed greater than 3 days. If they have asymmetrical pain, swelling, discomfort, think of DVT. If there's chest pain, hemoptysis, dyspnea, hypoxemia, that's difficult to explain. With underlying diseases, you should be alert to PE. In case of clinical deterioration, hemodynamic instability or cardiac arrest, which cannot be explained by other causes, again, massive PE should be considered. There are a lot of cool little pictures on Twitter where you can see massive thrombi floating through the right atrium, right ventricle, and some cases, a place in Detroit of them, angiovac extraction of these clots. Or you also look for D-dimer, and if COVID-19 patients stable with D-dimer is progressively elevated, then you should think about DVT or PE. And imaging tests, you should do bedside testing, so that ultrasound, and they have not suggested doing a CTP protocol to limit exposure of personnel. From the guidelines for the International Society of Thrombosis and Hemostasis, generally if D-dimer is markedly elevated and prothrombin times prolonged, with a platelet count around 100,000 or so, with a fibrinogen level less than 2, if there are no other concerns, and start prophylactic low molecular weight heparin. And for those who do not have all these, just monitoring is what is recommended. What is the Emory protocol? So level 1, no VTE and D-dimer less than 3,000. Low molecular weight heparin is 0.5 milligram per kilogram per day, and discharge with 7 days of DOAC. Level 2, no VTE, but D-dimer is now greater than 3,000. Again, low molecular weight heparin is 0.5 milligrams per kilogram Q12. You could also consider heparin low standard, discharge of 4 to 6 weeks of DOAC. If level 3 is known or suspected VTE, the higher dose, which is low molecular weight heparin, 1 milligram per kilogram Q12, heparin at high standard, and discharge with 3 months of DOAC. And it's important that in literature published this past weekend, it was shown that low molecular weight heparin may also reduce or reverse DIC in the setting of mild thrombocytopenia, which means around 100,000, PT prolongation of 14%, and elevated D-dimer levels above 3,000. What about ACE and ARB in COVID-19? As you know, we just talked about earlier in the presentation, COVID-19 enters the cell to bind to ACE2. But what it does is because of the downgrading of ACE2 and less availability of this receptor, angiotensin 2 and angiotensin 1 cannot be converted into angiotensin 1 to 7, angiotensin 1 to 9, and there's accumulation of angiotensin 2, which causes acute lung injury, adverse myocardial remodeling, vasoconstriction, and vascular permeability. And both ACE inhibitors and ARBs can reduce angiotensin 2. The proof is in the pudding. This was, again, this just came out over the weekend, that the persistent death rate was reduced in patients who took ACE inhibitors and ARBs versus those who did not. So societies have come out with recommendations, multiple societies come out saying, do not discontinue ACE inhibitors or ARBs. What about cardiac arrest? So there was interim guidance from American Heart Association, the Emergency Physician Group, and the anesthesiologist suggested that, as you know, we run in a code blue, and most of us are not wearing PPEs, but they suggested strongly recommended don PPE before entering the room, limit personnel, and consider mechanical CPR devices such as the Lucas device, of course, communicate with COVID-19 status for any new providers. Again, the recommendation was to intubate early. As you know, we have teams who go in and intubate patients in the hospital who are fully protected with protective gear. And the recommendation is to intubate early and connect to mechanical ventilator when able. And again, consider resuscitation appropriateness, addressing goals of care and taking into account patient risk factors for survival. What about pharmacologic therapy? As you know, chloroquine and hydroxychloroquine are out, but there are drugs that are currently being used. But at Emory, there's a trial with remdesivir, which was a agent used in the Ebola crisis, which prevents RNA replication of these viruses. And also there are drugs such as tocilizumab and sarilumab, sorry about the pronunciation, which bind to IL-6 receptors and prevent IL-6 receptor activation, preventing IL-6 signaling. So these are immune checkpoint regulators, and these are again in trials right now. Other drugs, aspirin in the pre-hospital phase in COVID-19 patients, it may reduce ARDS. There's some literature report on this over the past weekend. What about dual antiplatelet therapy, putting in somebody who has had a recent PCI or had a PCI and was COVID positive? You should note that the DAP does increase alveolar hemorrhage. In patients post-PCI, recommendation was to use ticagrelor because besides being a P2Y12 inhibitor, ticagrelor inhibits equilibrative nucleoside transporter, ENT1, that inhibits cellular adenosine uptake and reduces sepsis and lung injury. So, and again, recommendation of platelet counts was that if it was greater than 50,000, continue DAPT, between 25,000 to 50,000, consider only ticagrelor, and less than 25,000, discontinue ticagrelor. This morning and yesterday, there was reports about famotidine. It was noted in China, survivors in China who are on famotidine for pre-hospitalization for heartburn had a 14% mortality versus 27% were not on the drug. Drug binds to papain-like protease that inhibits viral replication. And Northwell Health has an IV famotidine trial for the drug dose, which is 9 times the standard oral dose. What's happening in Emory Healthcare? Bob alluded to this. The remdesivir trial enrollment is complete. Results may be out this week. Of course, there's the COVID-19 vaccine testing that is a study that is being kind of taken at Emory right now. COVID-19 antibody testing has started at Emory. You should know that 21% or 2.7 million patients were asymptomatic in New York. And I guess these are symptomatic patients that carry this disease. Outcomes of mechanical ventilation at Emory Healthcare to be reported, I think, this week. In New York State, the mortality for those patients who were ventilated in certain centers, such as in Elmhurst and Northwell Health, was very high. But we'll see what the outcomes are in our group of patients. Of course, the important patients are healthcare workers. It should be important that there have been 9,282 healthcare workers who are now COVID-19 positive in the US. In the place where I trained with my residency training, 104, greater than 1,000 were infected. In Wuhan, the initial exposure was 3.5%, but then they brought in 42,000 workers with no conversion, strict PPE protocol. In Bergamo, they're totally unprepared. The 10 to 13% got infected, with around 12 out of 36 cardiologists, including 12 out of 36 cardiologists, and 150 healthcare workers have died in the Bergamo, North Italy region. Our PPE is currently what they call level 2 in China. In China, they use a level 3 PPE for critically ill patients with hazmat suit, full face shield, and a third layer of gloves. Healthcare workers in Wuhan who went full PPE and quarantine with no family contact for 3 months. Again, they had very low exposure. PPEs do work. This article in the BMJ, came out last week. I don't know what the reference is, 2000, but it came out last week. And all these precautions were looked at. I guess it's a little older article, but again, this showed that PPEs do work in severe acute respiratory syndromes in preventing disease. I don't think this is very specific to COVID-19 per se. That's all I have to say, and thank you for allowing me to present this today, and we'll all take questions.
Okay, great. Thanks so much. I will take questions. You can either type them in your chat box or you can text them to me. So we'll start off with a question from Bob Taylor. The association with social vulnerability is clear. So this looks like, is Saba still on?
Yes, Dr. Mehta, I'm still on.
Okay, great. So this is a question for you. So your data are quite convincing. My question is, how much does this contribute to the very large difference in mortality? For example, in Georgia, the majority of deaths are occurring in African Americans. What other factors, if any, do you think are involved? Is it comorbidities, other factors?
So we think it's probably multifactorial. So of course, comorbidities like obesity, hypertension, metabolic syndrome disproportionately affects African American communities. We did try to adjust for that with the comorbidity score that the Medicare CMS releases, but it's not complete. So I do think that is one factor. Other things included are, access to healthcare. So we didn't look at insurance status or how, close the hospital is or the quality of the hospital, the number of beds, etc. So I think that is also definitely something that could be a factor. And another thing, unfortunately, is, like biases that minority population have when they try to seek healthcare. So those are all factors that could be contributing to these disparities.
I'll ask a question to Ahmed. Do you feel like the fellows have been, the ones who are in the CCU, and since you've been interacting with them, how do you think people are handling this from the fellows' perspective?
I think we're handling it pretty well. Initially, there was a lot of, in terms of the role for the fellows, and I'm talking about Midtown. I'm not sure EUH, probably also there is some certain protocol. And initially the CCU was 41 ICU that was designed to be the CCU, but then it's converted to COVID unit. So we started running in the 11 ICU. I think they are now with kind of like more protocol. We know what to expect. We always been using the PPEs, even with the patients that they are not they're not proven to be COVID positive. I think we're using a little bit of protection. And we communicated very well with Dr. Williams, and there's a lot of things that the fellows were concerned that's been addressed, and some of them I'm still there. We're kind of working on some of the solutions with the program director and the chiefs.
Okay, thank you. We have another question for Dr. Rab from Bob Taylor. In terms of decreased STEMI volume, what about other factors such as decreased stress associated with work, decreased pollution, etc.? Could there really be lower number of STEMIs?
I can't answer the question, but probably it may be a factor reducing both by pollution and also the stress. But the other factor is that if you notice that the world map, pollution levels are really clear over large areas of China and even in this country. So there must be a factor, but we'll never know because we don't know what's happening at home. I know of one patient of mine who had sudden cardiac death at home, but I will never know because I don't know who will be collecting this data to suggest that they really died of a STEMI at home or something else. So I don't know, but I think those factors may probably contribute. But where is that data? How we collect it? We don't know that. Now, I'll just tell you though that there are two registries. SCI, or Society of Coronary Angiography Intervention, has a registry of STEMIs and COVID-19, also another registry on shock, and they're trying to get that assessment both from physician practices and the practice in the hospital, see what impact it has had so far. So that's the best answer I can give you right now.
Okay, we have a question from Elena. The strain COVID-19 patients put on the medical system may correlate with social vulnerability index just by their geographic association. Is there a way to discern the two?
So yeah, that's a very interesting question. So the social vulnerability index actually does not have any component of geographic association with it. So when you just look at a raw SVI map, you'll see that there are areas in very urban areas like, New York City or, like Chicago, where there's a lot of access to healthcare. So what is kind of interesting is that when you look at our, the map, the social vulnerability index map, you'll see that areas around New York are not really as red as certain areas that are more rural. but I do think, it is important to kind of also study more of like the SVI index and rural areas in terms of COVID-19. And that is something that we are planning to do as a next step.
Okay, we have a question from Dr. Sherman. Do we know if reported young strokes in young people, were they anticoagulated like they're done at Emory?
So Stan, there were the number of hospitals in New York, particularly starting from Mount Sinai and Northwell, noticed that young people between ages of 31 and 51, and there are few of them, presented with unexplained strokes, presenting with a day's history of migraine-like headache and strokes. Now, they just came in with strokes, not with respiratory symptoms. And then they were known to be COVID positive, and they had clots in the large vessels, such as the carotid and large proximal circulation vessels to the brain. And now, I do not know what treatment strategy they took, whether it gave lytics or thrombectomy, I don't know that, but that is what reported from 3 or 4 different centers right now. I've not seen a paper yet, though.
Do we know if people who are pregnant or delivering around this time, and if they're COVID positive, do we know anything about their outcomes?
So as you know, Pooja, there have been a number of cases that have come on national news showing, at least I know there was one patient from Elmhurst who was COVID-19 and pregnant, and she had a C-section and delivered her baby, and baby was COVID-19. That woman quickly recovered, and there was this thing on TV that showed her holding a baby like 20 days after her discharge. But I don't know in the collection of literature how many patients were positive and how many delivered. I don't know all that, but there are very few cases reported in national media.
Okay, any other questions, thoughts? We're almost at 8:30 here, so if nobody else has anything, then we will close the conference. Thank you so much, everybody, for joining.
The preceding program is copyrighted by Emory University.